that we have been invited to present in this important session that relates to one of the critical components of collective care nowadays, which is the global perspective on patient engagement. So this should work. Hello? I'll do it from here, if it works. So I try to be brief, so we have more questions, we have more time for the panel. So I will try to present just 10 slides, making a short description on what is patient engagement, and trying to, I would say, make the case that I believe is already made in many ways. But first, just trying to define what is patient engagement, just mentioning that it's a process of facilitation and strengthening the role of those using services as co-producers of health and healthcare policy and practice. Remember, we are the few industries where the users, the patients and families, are not that much engaged as in other industries. And that's particularly curious of us. So the topic is named A Global Perspective. And of course, all of us know that it's easier said than done. And again, there are not many reports on the level of patient engagement around the world. So I maybe couldn't describe much on the title of the presentation, but again, there is a big challenge that we need to go through, and later I will say why, but we need to find a way through everywhere for everyone all the time, because unfortunately, patient engagement for the moment, it's a luxury of few, and hopefully we can change that. And why patient engagement? Well, I mentioned here that it's because it works, it's shown by the evidence, and it's the right thing to do. Why? Because it's so obvious that we need to include users in decisions for them to be more engaged and have a better results. There is no matter of discussion. And there I leave some references I found about systematic reviews on the patient engagement effectiveness. Of course, it's variable in every setting, but it's clear that there's a positive effect that hopefully could be explain better in the future on what are the critical factors to make it happen. And again, it's something that it's somehow all news for the world. And finally, on the right, you'll see that probably, I don't know if he might be the guy presenting this, because CAHO created a report that was recently launched on the critical factors for patient engagement in India. So probably not the one that I should share this with you, but you have the evidence, you have your own reports adapted for the culture of India. So my sense is that there's not much need to describe why we should be doing this. And how we should conduct patient engagement. I like to use references in whatever I say. So this is a paper from 2012. Okay, so again, all news. And here I just mentioning for your reference later, I understand that the slides will be available to you, just 3 tables that describes the domains of patient engagement. One is health literacy, how we can help patients and families to understand what is the process of care. The other one is shared decision making, because if we don't help patients and families to contribute to decisions, things will continue the same. And finally, there are a number of interventions that helps, again, the process of care to be improved, because we are one of the few industries where process of cares are not designed with consumers. And that's, again, curious. So we have literacy, health literacy, the shared decision-making, and different process of care. But this is from 2012, and this has been the guide for patient engagement for many years. But things changed. And how they changed? Because now we talk about co-production and co-design of healthcare. So for that, you may have heard from Peter Lackman. I don't know if he made it to the room yet. So co-design is a phase where users, before deploying services, they work in trying to understand and trying to contribute to the process itself. And this came from something called Design Council. Design Council are engineers There are people that work in design of services and products. And that's the double diamond of design that I leave you as a reference. And on the right side of the screen, you will find one of the conceptual papers from Paul Batalden, which is one of the inspirers. You just celebrated Duran 2 days ago, when Batalden is maybe more recent in time, but he's one of the key people in quality of care around the world, and he developed this framework for co-production and co-design. So, recapping, the evidence is there. We need to work on health deterrence interventions. We need to work on shared decision-making, and we need to engage patients and families in process design. And I will give an example at the end of my presentation. And here we have the concept of co-production and co-design with the current frameworks. And also Peter mentioned to you yesterday, and I want you to revisit that concept, is that, of course, every health system is doing the best they can, and probably we're all facing in different phases, so we're all facing at different speed, but you have quality 1.0, which is based on inspection, which is, of course, had made a lot of contributions. Then you try to work on reliability, how to make the process stable and have less defects. That's 2.0. And finally, you have co-production of health. So you will see more and more that patients and users are more engaged, are more involved in the design phase, and that's 3.0 for the moment. Eventually, there might be a 4.0. But this is where we all should aim, and it doesn't matter that we're still in phase 1.0, but we need to transition in engaging more patients and families. And this is another resource that you have in your slides that came from another service design company in the UK that's called the co-production ladder. So up in the ladder, you have the ambition that we're all looking for, but look, you can see there in what stage you may perceive yourself. Care done to me, you're just a passive actor. Care done for me, you're somehow start to engage the patients, but the last steps of the ladder are nothing without me. So these stages of coercion, education, informing, consultation, engagement are phases that probably represents what we are now, and eventually we'll get to the co-design and co-production phases. So again, I'm just leaving you these references for your consultation afterwards, but you have your own resources from CAHO now. So it seems that you are on the right track. So just getting to the end of my first section of presentation, we need to think differently about quality of care in general. And this is a framework that was created by Margaret Crook from, in that moment, at the School of Public Health in Boston, in Harvard. And she created this framework describing that health is the most important output of the health system to be hopefully achieved. And that's the aim for quality of care. We need to improve health. Then we need to improve confidence in the system. So users and families have to have trust in the system, and that's the confidence built by satisfaction, recommendation, trust, and care uptake. And the trust piece is very important. You will define the health system by the trust the users have for it. So there you have the critical point of having a clear understanding on how people see their own health systems, and probably how that's related to the engagement they had had. And finally, economic benefits, because bad health systems impoverish societies. And that's a critical point to have in the future. So finally, short story. I came from Argentina, the other side of the world for you. And there's a province called Mendoza, where the wine is produced. So if you see wine from Argentina, it's produced there in Mendoza. And we are doing now a clinical trial back at where I work in the Institute for Clinical Effectiveness, where we're trying to redesign care for diabetes. So you see there that we're trying to co-design with providers, decision makers, but mostly patients, how the care model should be to improve the adoption of evidence-based interventions for diabetes. So this is a good example on how we're just trying to translate the evidence and the theory to practice. So that's another example for you to have. So finally, that's a picture of a house in Austria, in Salzburg, where this concept of nothing about me without me, that is the motto for engagement, was created in 1998. So we have been trying for almost 30 years to change the way we deliver care, having the users with us engaged. But keep that in mind, and I believe it's a good summary on how engagement should be defined. So with that, I have tried to talk about what is engagement, why engagement should be used as an intervention to improve healthcare. We have visited some of the big domains of engagement: shared decision-making, health literacy, and interventions to design care. We have went through the concept of co-production and co-design. I gave an example from work that we're doing back at home, and then summarizing my intervention with this phrase, nothing about me without me. With that, I end my presentation. I have one more thing to say, and there you have my email in case you need to reach out for me. Thank you. So I need to do something with you for people around India and the world, and it's to share something that ISQA recently produced, led by an Indian fellow colleague from ISQA. So I invite the stage to Dr. Anu Pichumani. We're good? Yeah. So, Dr. Anu Pichumani and Dr. Shinu Shira, that I also invite you to the stage, are part of the authors of a report on how to make patient safety more impactful in different settings. We have the action plan from WHO, but some experts from ISQA have tried to work together in creating a new contribution to the cause of patient safety, what is so dear to CAHO. So us, the ISQA people, plus, well, BK also a member of ISQA and our facilitator, would like to give CAHO a copy of the report. So I invite, if you're here, Dr. Vijay Agarwal. Okay, thank you so much. I know Dr. Lalo Joseph is with us yet. No. Okay, she might be elsewhere. She's doing a lot. So Dr. Vijay will represent CAHO. And so, good morning. You look great as usual. Well, thanks again. Thank you. So this report is available on the website of ISQA for you to download and to hopefully use in your settings. More pictures, okay. I never thought I was going to be in so many pictures as Jeffrey, but it's no, it's not a competition. There's no chance. Thank you so much.
Thank you.
Well, thank you very much. Well, we're good with time. We did very well. Thank you.
Just one question to you, and we didn't get started on the panel. We're talking about patient engagement, and we talked about global perspective. Here we have a situation where the ratios between the nurses and doctors and patients is very less. I believe that doctors, say in the West, may see 10, 12 patients. In here, we have 60 patients. How do they engage? So the model and standards have to be different.
It's not possible. The ratios in more resource settings from nurses to patients is 1:6 in the floor, 1:2 in ICU. So it's very difficult. Right. I hope that at least it can provide basic care for those 60 patients of shift.
So I think between CAHO
but one thing, engagement is not only for hospitals. Remember that most of the care is being given at the primary care settings. And there, hopefully, ratios are a little bit better.
Right. So I think we try to find our local solution. So between CAHO and Patient for Patient Safety, now we are creating 4-5 minute videos where if the doctor doesn't have time to explain the procedure, the risks, right? At least they will be able to see the video. So I think we have to find ways and means of, we can't increase the doctor suddenly. So we have to find ways and means of saving time of the healthcare professionals so that they are not stressed and we can find technology to use it, and I hope they can. Can you all please move forward, because it'll be nice if you're all here up front. Yeah, sorry.
But no, but adding to that, of course, what's happening is that patient care should not be centralized in physicians or even nurses. Could be also delivered by social care workers, by the different professions around healthcare that are more trained to engage people and to deliver simple interventions that hopefully will help people to. There are 3 questions. I don't remember them all now, but if you look for this nothing about me without me, it's called the Ask Me 3 questions. 3 questions that every patient should ask to the health provider. So that's 3 questions could be an example, a very simple intervention that could be used.
Thank you.
Thank you.
Thank you, Ezequiel. As always, a wonderful, terrific presentation. And I want to make use of this opportunity of your presence in person. We talk about co-production, co-creation. And there are several stakeholders involved. But to my study, what we have done is that very few participate in that. So what, in your opinion, are the key stakeholders who really actively contribute to co-design and co-creation activities?
Well, first, people like him, because you are finding ways to tell people that they can really be engaged and participate. Then, as usually, whenever we're facing change, we need opinion leaders that share with peers that it's possible, this works and this is important. But I have the sense that all should be, I would say, working in an ecosystem cultural ecosystem where people are not afraid to speak up and to be engaged in. Because there's another concept that I haven't mentioned, which is how is to be an activated patient. Activation, it's another well-known concept that describes that activated patients do better. So we need to share with people that if they are activated, they will do better in the care. So hopefully that message.
Yeah, thanks so much.
Thank you so much. Actually, today we have a very unique situation. We have 3 doctors who are patients and another person who is a healer, right? So they're all attending to doctors. But today, they're going to be speaking in their capacity as a patient. And they're going to share 2 things. That during their health care, when they went through their journey in a hospital, how could they prevent harm? Because they knew. Because they were doctors, they knew, and they could stop and prevent harm. And the other they're going to share with you is that in spite of their knowing and their warning and cautioning the healthcare provider that a potential harm is happening, it still happened. And I think this is a learning for all of us today, because you relate to it. All of us are only in one of the 3 categories. Patient, would-be patient, or a caregiver. And in all those 3, it's very important for us to hear their stories. And thank you very much for being so open. We had this discussion yesterday. I was really touched that you were willing to share. So could I start with you, with your story? You have a mic next to you. I'm sorry we have given less time to all of you. So try and do it in 5 minutes, and then we'll have another discussion. Thanks.
Thank you so much, sir, for this honor of being here in this panel. Yeah, so I have spent 54 years being Charu. I have spent about 35 years being a doctor, but I have spent half of my life being a patient. And I want to say this is all my episodes happened in accredited hospitals. My first encounter with healthcare happened when I was 26 years old, and I underwent a diagnostic ERCP and ended up with pancreatitis. And it was because I was a second-year MD student, and I had my medicine well. I was able to diagnose most of my symptoms. Only 1% of patients survive pancreatitis. And I think I am sitting here because I would tell the doctors that I'm having perioral numbness and please check my calcium, or I'm having a catch when I'm breathing, so there is probably a pleural effusion, please get an X-ray chest. And I was treated very condescendingly. I was not given analgesics. I was told the doctors make very bad patients. I was told, be a patient, don't be a doctor. And and I think I survived only because I was giving them symptoms much before they would become signs or they would get investigated. So, and the last 26 years, I've had multiple hospitalizations because of intestinal obstruction, and I'm going through nutritional deficiencies, and my quality of life is completely shattered. I can't wear a sari because I can't stand long enough to wear it. I can't wear heels because I lose my balance. I have fogging of memory because of the medications I have to take to suppress my pain, and I'm still judged.
And were there instances that you tried to convey and they didn't listen?
Oh, yes, all the time. My father had to run I used to get one single injection for pain the whole day. Now I think everyone knows pancreatitis is a severely painful condition and you need round-the-clock analgesics. My father had to go and the doctor told him that your daughter is acting. She's doing a drama, that she's in pain. This was told to my dad. And every night, my father had to run to find a senior resident to get me painkillers. So, but this was not the only situation. I've been into the ICU 3 times. And there was a situation where I had episodic pain. And I was not given painkillers again. 26 years after my first encounter with pain, I was still not given pain medicines. And when I got upset, they gave me a patch. Patches are becoming very popular, but I'm a pain physician. And my 15-year-old son came in the next day, and he told my husband that, Dad, you need to call a neurologist. Mom's hands are very clumsy, and she's slurring. And then it suddenly struck me that I've got a patch on. So in an accredited hospital, there was no handover by the doctors or by the nursing staff that I had a patch on. And I could have ended up with respiratory depression. My respiratory rate was 10, I believe, that night.
It takes a lot of courage for somebody to come and speak up. And this happens to be Dr. Give her a big hand. Thank you, thank you.
Thank you so much. This is the first time I'm sharing my story with a crowd here. And trust me, this morning I was a little emotional and teary-eyed. And I think my fellow panelists.
You make us as well. Jeet.
Thank you, sir. Myself, Jeet, I'm here not as a doctor, but as a patient. I'm going to share my experience. I already have had undergone 2 major surgeries, one for my cardiac problem and another for my L5S1 spine. When it comes to the patient engagement, we speak volumes about, we have to engage patient, we have to do that, this, do that. But when it comes to the practical part, that is where we have, I think there is a big difference or gap. Because when I go to a hospital as a patient, I never introduce myself as a doctor. It's Jeet Patwari, what I write. Because number one is I don't want to take that undue advantage, or maybe I don't want them to know that I'm a doctor, so that they are more cautious. So the first thing that comes is the consent signing. I'll tell you about my experience. I was given the form, 2 languages, one in English and Hindi, but I was never explained that these are the things. यहाँ पे sign कीजिएगा. I signed. I was admitted in the IPD and I was wearing a full sleeve pullover. 2 young nurses came to collect sample, and I asked, what do you want to do? They said they showed me the vacutainers. They didn't even have time to explain. So and they said, pull up your sleeve. I did, and instead of a tourniquet, they tied a glove, hand gloves here. I did not want to interrupt, just wanted to see what they were planning to do. And they were trying to find the antecubital vein here. They could not. I could see the needle going inside, coming out again, going inside. No blood was there. And finally, they did a double puncture and there was a hematoma. And that was enough, I said. I said, ma'am, why don't you try on my other hand or call somebody else? get a proper tourniquet, and then tie it up properly, check the antecubital vein, and then collect the blood. They said, okay, sir. And somebody came. Again, tourniquet was tied. They did not, I asked, for what do you want to collect the blood sample? They said, we want to do some tests. They did not have the patience to, the previous day I had my CBC done, the LFT done, my renal function tests done. They drew the sample, they did not explain. They drew the sample again, they took the sample again on the second day, I'm in the hospital, and my tests were done. So there was a repetition on this. Now, my question was, why do I have to donate blood twice? And I'm sure there are instances where, people are exposed to, unnecessary radiations in the form of X-rays and CT scans and other those things. So I feel that right now also we are, going to share our experiences. But I think that this should not be confined to the four walls here. People who are involved, I teach quality in many institutes, and few of my students from IIM Shillong are here. We had detailed discussions on this, but I feel that as a patient, I have felt or experienced what we teach and what we actually follow in the hospital. There's a big gap. We talk about NABH, the full accreditation, we talk about JCI, people from ISCO are also here, my respected seniors are also here. But I think there's a big gap in this, and that is where I think we should focus on. So at the end of the day, we are working for the patient.
Thank you so much. Thank you. And I think this is a great point that made. I believe that in India, the attrition rate in hospitals could be anywhere upwards of 30%. So when we have an accreditation process, everybody is very alert. They are taught about accreditation and what to do. But the newer people are always coming. They're not ingrained in the culture. So this is a constant journey. It's not a one-time accreditation or not a one-time audit that we go through.
By the way, this was done in one of the best hospitals in the country, located here in Delhi NCR, and NABH full accredited, and the JCI hospital. JCI was, they got the accreditation later, but when I was admitted, it was NABH full accredited hospital.
Thank you. Malathi, can we shift over to you? You're far away there, but share your experience and...
Hello, everyone. So as everyone said, I'm here as a patient. I'm a known case of Crohn's disease. I'm on triple immunosuppressive therapy currently. And I don't know whether you believe, maybe you will think that I'm looking slim and thin now. I was 35 kg before 1.5 years, and actually I'm gaining weight. So when people look at me and say, you're thin, actually I say, I'm gaining weight and I'm happy now. So, but what went wrong? We are all here to talk about a patient point of view. What went wrong? Every time when I visited the clinician, that something is wrong in my body. As a patient, he or she who owns the body will know something is wrong. It's been 8 years. Every time when I visited the emergency department, the gastro department, I was telling that something is wrong. But every time I was told it's normal. Everything is normal. Your blood investigations is normal. Your imaging is normal. You look normal. You come to duty. You're working normal. So please go back. It's nothing wrong. And every time I was loaded with a lot of morphines, a lot of sedatives. And after some point, they said, go to a psychiatrist. They said, you are an anxious person. You are hyperactive. So you're thinking too much. That's why you're not coming and accepting that you are perfect. So as I was put up on antidepressive, I was put up on anti-anxiety drugs. And after some time, when I ended up in the emergency department for laparotomy, where I have lost now my 2 feet of my gut, then they accepted. So at the point in the ED, I asked my consultant, you never believed me. I said something was wrong. So as a patient, I request all the healthcare professionals here, always please listen to your patients. We know something is wrong. Yes, maybe some investigations may show normal, but you have to believe in your patients. We have been told from childhood that we don't lie to doctors, we don't lie to lawyers. So a patient will never lie to a doctor. So that's the major problem. If I would have been diagnosed 8 years before, I wouldn't have landed up in surgery. So that's the take-home message I wanted to convey to every healthcare worker here. Please listen to your patients so that we can avoid major complications. If I have time, another major point, I was in ICU for 60 days. I was in hospital for 3 months and I was in deathbed. But I wanted to get the word from my consultant, whom I believed a lot. Every day I wanted to see him, at least once in 2 days. When I begged to see him, I could never see him because if I see him, I feel like I'm seeing a God who tells me whether I will live or not. So the opportunity to see whom you want, which consultant you want. As a patient, I have the rights. I want to see this person. A junior comes and says that you're okay. I don't believe. That's a patient point. Yes, I'm a healthcare worker. I know that something is wrong or bad or good, but I want to have that belief and confidence to survive back. The same for caregivers. Please ask the doctor to talk to the caregivers. My mom and dad was crying. My twin boys came and they cried seeing me in the deathbed. If the doctor would have assured my mom, dad, and my twin kids, they would have been satisfied. So that I know we can't assure 100%, but the conversation should go beyond, which is being neglected, especially if you're doctors. The presumption that we know everything and the lack of communication is a major problem for us, especially those with chronic disease. So that's the message I wanted to share.
Thank you so much for sharing this. And I think this is a great segue, right? You mentioned about empathy, that you would have loved if the doctors and the nurses there had come and spoken and given comfort to your parents. And I think empathy is a very important thing. And I think, Sheetal, that's a very good segue for you to come in. She's not a doctor, but what she does is healing. And she has her own way, and she runs this nice company. And you talk about it very briefly, and then talk about what's the impact that you have seen.
Hi, good morning. So it's a non-profit that I run. It's called Clownsellers Foundation. The therapy we do is called medical clowning.
Can you put it up a little up?
So the first thing, let's start with the simple truth. Patients are not just cases. They are simple humans who are extremely afraid and in a deep need of connection. So the first thing when a patient enters a hospital, the first thing they lose is a smile. How many of us actually see a patient smiling? So when as a medical clown, I walk into a hospital and in wards, I don't walk in with a stethoscope, but with a red nose. If any of you have seen a clown, this nose is our smallest mask. And how does it help? Why does it matter when we talk about patient safety or patient-centric care? What does that mean? Why is it important to bring patient to the center? Because healing is not just emotional well-being. Healing is not just physical recovery, but also emotional well-being. It is a mind-body connection. And if I have to share, so we've been doing clowning for 8 years now. And we have had so many experiences where we've seen healing happen. So every Saturday we visit this hospital called Chacha Nehru Bal Chikitsalaya, where there was this young girl who we were told that she will not survive. She had multiple failures, and one thing that stayed constant while her health was deteriorating was that she was always asking for the clown, and she wanted us to dance on a Salman Khan song. So if you remember that Tal step, so that is one step that she wanted all of us to do. So there came a time when she could not even move. She would only blink, and all the clowns had to be around her bed dancing for her. After 3 months, she actually went back, healed, and she walked out of the hospital. This is the same person who we were told will not survive. Did clowning heal her? Definitely not. But it gave her strength and something to look forward to every week, and that helped her fight with the disease. Why does this matter? Why should we look at emotional well-being or about this whole healing? Because, like Sir mentioned, it is about empathy. We are dealing with people here. So if we keep looking at the disease and if we keep treating the disease, we are missing out the person. But the moment we start looking at the person, the healing will happen. How? Because when a person is feeling emotionally safe, like even when ma'am was sharing that nobody was listening to her despite being a doctor, or both the doctors when they were sharing, there is this sense that we are not in control of the situation, and we are constantly feeling that there is kind of a distrust that happens. But the moment we start feeling emotionally safe in a hospital, trust starts building. Cooperation will happen better. And then the body will respond better, simply because of mind-body connection. And that's where medical clowning meets patient safety. And as a medical clown, when we enter a hospital ward, we give control to the patient. So it's up to them whether they want to engage with us, they want to just watch, they want to laugh. And we kind of try to match their energy. We don't try and perform for them. We don't say, hey, look at us. So a simple act like this. Hi, sorry, I'll use you again. Hi. 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 Oh, hi. 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 So something as simple as this it is actually giving the patient the control to what they want to do. If they don't want to play with us, they will not play with us. So for those of you who do not know what medical clowning is, it's a therapy wherein we dress up as clowns, just the wig and the nose. We have some puppets, we do some storytelling, and we try and engage with each patient one-on-one for 3 to 4 minutes. The idea is that they should heal, they should start smiling, and they feel better. And for a little moment, they gain control of how they want to feel. When we talk about healing, it's a holistic approach. We are not just saying that there should be medical clowning, but arts therapy, music therapy, sound healing, any of these therapies could come in. So now we have also started training medical professionals into these approaches, which ensure that empathy is embedded in the healthcare system. So it is not just looked at as an add-on process, people coming in and doing it. So it's not just a business for us, but people who are inside the system are actually focusing on the human. When they enter and start doing the procedures, they smile and they speak to them. And that would change something in the healthcare system itself. So in the end, I would just want to say that when we are giving out prescription, can we also give prescription for doses of laughter? And as a reminder, and laughter always acts as a reminder that healing is possible. So for me, my hemoglobin for 30 years was 9.5. No amount of beetroot juice, carrot juice helped. At 30, I started clowning, and now my hemoglobin is 14 or 15. It has not gone down. So that's the power of laughter.
Thank you, Sheetal. I think when you, all of you as healthcare providers, when you now see a doctor, think of her, smile, remember the red nose, and I think you would be, your emotions will be very positive. I have a question to the three of you, not to you, Sheetal. You've been doctors. You are also patients. Every person in the hospital actually wants to serve, right? The nurse comes in to serve, the doctor comes in. What holds back? What holds back the engagement? And anything else that you wanted to add?
I'd like to use Dr. Ezekiel's presentation that it is patient engagement and nothing about me without me. And yes, Mr. Mittal, you had mentioned that doctors don't have enough time. And I would like to again point this presentation that there is a team. You can utilize that. Psychologists, social workers, dietitians, and doctors. But being doctors does not stop us from being a psychologist or a social worker or a dietitian. And we have to be open to learning everything every day. And I think a positive regard for your patient. He may know more than you. Because yesterday when we were planning the session, I learned a couple of things from Mr. Mittal about MRI. I wish you would share that. So that was a learning experience for me. Please be open, listen to your patients. They may know more. Empathy is very important. I think teamwork is supremely important. And it is all about the patient, isn't it? So
Last
it's
5
patient-centric treatment that we are supposed to be giving.
I would request this is the last
Thank you
5
so much.
minutes.
Yeah.
I feel there are three factors which can be considered. In our medical college, we were taught about anatomy, physiology, biochemistry, medicine, surgery. We were never taught about, how to deal with the patient. What we learned is what we saw from our seniors. Number one. Number two is the attitude which we as clinicians have. Maybe we do not want to spend too much time with the patient at times. Number three is, and maybe especially in the government hospitals across the country in India, we have huge patient load. A few of my seniors, they have to, attend to somewhere around 60, 70 patients within a span of few hours. There's no time for, to explain what is there. Also, it depends on the attitude. And for the nurses also, this is something which I have felt personally, because the shortage of nurses maybe, or maybe because of the training and the other things which are imparted to people. We were never taught about this. Now that this NABH and the accreditation and all those things have come, we have got the further figure of quality. Geda Gyani sir, Tupil sir, and other people are here. I think that the wave that has been created in the last 2 decades, it has changed. But I come from a tier 2 city. We still have the same kind of, except for Guwahati, which has got the largest number of big hospitals and accredited hospitals. The other cities are still lacking. There's nothing. We still follow that conventional kind of practice.
Malathi, can you just briefly mention?
So, with regards to chronic disease, engagement of patients is more vital than any other acute disease. So, right from the planning of therapy, where we have multiple options of drugs, the patient should be engaged in choosing the right drug. With why this drug? Is there any alternate options? What are side effects? Because they're going to take the drug for quite a long period, maybe till death. So, patient engagement starts from the treatment planning. And follow-up is a major problem in chronic diseases. Patients, once they feel like I'm feeling normal now, I may not go back to my consultant. How to engage the patient? Who is going to contact? So like we have somebody called IBD nurse. They call me every Thursday. So that's the way the nurse engages me and reminds me that whether I'm okay, I'm taking drugs. So that's how we can engage from the hospital point of view. Otherwise, in the busy schedule, we forget everything if we are normal and happy. So that's most important for chronic diseases to engage.
Thank you very much. Yeah, there was this whole question on time.
No, just want you to, thanks again for your presentation and contributions. I'd just like to mention that, after my colleague question about what we can do, I have the sense that we need to let go the intention that care is only provided by one person, either a physician, nurse, or social worker, or whoever. We're a team. And we are also teams inside health systems. So as time went by, I still practice. I try to tell the people that trust me as patients that not being cared by me, they're being cared by a system. So engagement will do better whenever we don't rely on one people, but on a system of people or teams. Hopefully that happens. That's one thing. So and also volunteers, as you were saying, that people that are not probably trained as clinical providers, but they do a lot in different ways inside care facilities. And just to mention, I look for this simple intervention about engagement, which this ask me these 3 questions. I don't know, are these in the report? Are these in the real report? They asked me 3? Okay, well, so read his report, okay? The CAHO report on patient engagement has these 3 questions that should be asked every time we see a haircut provider to understand better what's happening to any of us.
Thank you. And since you mentioned it, I went for an MRI myself about 6 months back, and I was very tired running around, and I'd come empty stomach. And I was feeling very thirsty, so I asked the technician, can you get me a glass of water? And he said, sorry, you can't drink water. But I said, I'm parched. So he said, okay, take a sip. It'll wet your lips, but don't drink it. And I asked him, I said, I've never heard of not having water. He said, sir, we are doing your MRI and I have soft tissues. The imaging will get affected if you drink water because the water molecules affect. And that was knowledge for me, right? And hence, I think this technician engaged with me, asked me, when I asked a question, he didn't say, Google pad ke aaya hai, kya hai, you know, he actually answered, and I'm educated, not that education, I don't have to get the MRI again. So this has been a great session. You know, it's never enough to hear patients' voice, and I think that's it. But I'm going to ask Dr. Rana to do the tough job of summarizing what we could pick up.
Thank you, Somsa. Thank you, everyone. Thank you, Ezequiel, for your presentation and all. Thank you, actually, thank you all of you who are here in the early morning to be with us. And there are several stories similar to them, but the thing is, are we learning from them? We keep talking, and I'm very blunt on that. I'm sorry to say that. We can continue talking for decades, and we have been talking for decades in the last several years. Anything changed? Yes, things change, no doubt about it, but those changes are in tune with what we supposed to have those changes in place. And it's very difficult, as you said, sir, to summarize what, but I think it's my job at the moment is to really, acknowledge your contribution, not only for yourself, your family, but the whole of the society, which are looking for the volunteers like you to come forward and share your stories. So I would like to briefly say some of the points as takeaways. And it's up to you whether you take it or you leave it here. It's entirely in your hands. So first, listen to your patients. And that is missing. And I have been patient many times, and I have not that severe, but close to that. So please listen to your patients. Whatever they say, don't think they are saying something nonsense. Maybe for a healthcare professional, they sounds me something nonsense, but not for them, not for us as a patient. When we call a nurse, hey, I'm having pain. Oh no, it's happened. It's usual in this type of problem. Maybe different, maybe something else. And we had a very good discussions. We are not able to produce everything here in this short time, but those are the things which we need to consider. And again, I think we have been talking about patient-centric care. But do we realize what is patient-centric care? Patient-centric care means what we shifted from a disease treatment to patient to a person-centric care. So person-centric care or people-centric care means the patient in the center, the family around, and the community around. It's not just patient, because many times patient is not in a situation to listen to your comments. The family does. So we need to engage with the family as well to really provide the patient-centric care. And empathy has absolutely come forward. Empathy need to be embedded in our healthcare delivery systems. And also, what we talk about is that many times we feel these are normal things for you as a healthcare worker, as a doctor, physician, nurses, or whatever it is, because you are doing the same job, maybe with different people, correct? So you think it's my another day. But think about the patient. For them, it's the only day. And they are different. Every time they are different. And you should not think, oh, I have been collecting blood for last 20 years. Maybe I'm not having that much of blood in my body, like you say, multipunctures, So I think these are the things which we need to look at. So we are talking about patient for patient safety, how we engage with patients in the better care and the safer care of the patients. And if you remember what WHO DG, Dr. Tedros mentioned a few years ago, is if it is not safe, it is not a care. It's a very powerful statement. If it is not safe, it is not care. And I think time has come, we have to act now. Not tomorrow or day after tomorrow, we have to start from now. And I would urge every one of you to have a commitment before you leave this hall that yes, we would work all together, committed together for making life of the patient more safe. Thank you very much.
Thank you so much, sir.